good morning, good afternoon, good evening, wherever you are in this world. Happy to have you join us for the session on strengthening nutrition within the Humanitarian Development and Peace Nexus. My name is Martha Nakakande, and I work with the International Medical Corps and the Global Nutrition Cluster. I've recently joined as the co-group's Nutrition Working Group co-chair alongside Diana and Alberta. And Dan and Alberta, alongside with Kate, are going to be helping us in the backgrounds. Thanks again for your support, ladies. We will be hearing and gaining experiences from Action Against Hunger, presenting their experience in Ethiopia. And we will also have Corus International presenting the experiences in Mali. Please feel free to share your comments, questions, suggestions, additions in the chat. The questions will be responded to during the Q&A. I guess now the question then, everyone's like, what is the Humanitarian Development Peace Nexus? I'm sure I'll have a lot of sharing from the ACF team and the Corus team. I just want to say that broadly, we are looking at closer collaboration between the humanitarian and the development actors as they address the immediate needs, while at the same time trying to tackle the underlying issues of vulnerabilities. The idea is we should not treat these as two separate sectors or systems, and we should not work in silos. And of course, with this, it comes along with joint planning, better coordination, focusing on collective outcomes, and ensuring that short-term emergencies or short-term interventions can contribute to longer-term resilience. So we want to be able to reduce risk, strengthen resilience, and ensure that the affected population move from that emergency space and into better recovery processes. We could have a longer conversation about this, but I'm well aware that experiences speak louder. And on that note, I'll invite Dr. Adugna and Hailu from the ACF team to please share with us their experiences. Thank you very much. Over to you, Dr. Adugna and Hailu.
Thank you, Martha. So before we dive into the details of our Humanitarian Development and Peace Nexus project, I want to take a brief moment to share about Action Against Hunger and why we are championing the Humanitarian Development Peace Nexus approach so fiercely. At Action Against Hunger, our mission since 1979 has been to end hunger and malnutrition, particularly among children. Today, we operate in over 55 countries, providing immediate life-saving emergency relief alongside long-term sustainable development. Our work is built on 4 fundamental pillars: nutrition and health, water, sanitation and hygiene, food security and livelihoods, and emergency response. But over the decades, experience has taught us a hard truth, particularly in complex contexts like Ethiopia. Humanitarian aid is vital, non-negotiable, life-saving during a crisis. But to truly break the cycle of hunger, we have to address the root causes. This is why we champion the Humanitarian Development Peace Nexus approach. Through targeted development, we help communities transition from emergency aid to self-reliance, empowering them to withstand future shocks. Furthermore, by integrating the peace element into our programs, we actively work to elevate local conflicts that drive displacement and hunger in the first place. Simply put, treating a malnourished child saves a life today, but building sustainable food systems and fostering peace ensures that life can thrive tomorrow. Our goal for this session is to move beyond the theory. We want you to walk away with a particular insight and collaborative examples so you can design more effective nutrition programs in the complex contexts we work in. To take us from this global vision to the reality on the ground, I'm thrilled to introduce my colleague Hailu Gebisa. Hailu is a consortium lead for our multi-year, multi-partner program. He brings over 15 years of experience managing large-scale health and nutrition programs backed by a dual master's degree in public health and international cooperation. Most importantly, he spearheaded the development of Ethiopia's first ever national nexus framework alongside the Ministry of Health. So there is no one better equipped to walk us through exactly how this initiative is building resilience in conflict-affected and drought-prone communities. So please give a warm welcome to Hailu. Hailu, over to you.
Okay, thank you, Dr. Adugna and everyone. Good afternoon. Is here in Ethiopia. I'm going to present. By the way, is my slide is visible to you all? Please confirm.
Yes, it is. Thank you.
Thank you very much. So I'm presenting to you the Nexus experience gained by Action Against Hunger in Ethiopia through the programming of Humanitarian Development and Peace Nexus as one approach, as stating the motto as a means to consolidate nutrition investments and improve nutrition outcomes in Ethiopian context. So through my presentation, I will be covering a very highlights on these 5 key points. I will be introducing you about the Nexus, very highlight, and also why we need Nexus in Ethiopia, and the work done toward the operationalization of the nutrition-centric humanitarian development and peace nexus in Ethiopia. And also, I'll be covering the experience gained and the results through the Humanitarian Development Business X program implemented in Ethiopia for the last 2 years. And also, lastly, I will be presenting to you the key learnings and takeaways as a learning for all audiences gained so far. To start with, I will not actually get into detail of what does the nexus mean, how it will operate, but I will be giving you that as we all of us now, the global community currently faced different kind of challenges which are complex and interconnected. From the set of humanitarian crisis, which is very protracted, the development need across all sectors, and also the issues around peace building problems. And now the global scholars recommend this now that we need to have a coordinated and sustainable approach that will bring these efforts together and bridge the gaps. And Nexus approach is believed to fill these gaps, and it offers a pathway to address these challenges and is now recognized as a new way of working. Another name of Nexus, which in practice actually at the ground level is calling it as a new way of working. And now the key principles set at World Humanitarian Summit and at OECD is fact actually is that while applying a Nexus approach, it should not be a uniform across the globe or context, and it should be context specific and reinforce the existing national and local capacities. And also it should anticipate the crisis rather than reacting after the crisis has occurred. And also, while implementing the Nexus approach, we should be excelling the HDP divide or the gap, and by leveraging the comparative advantage of each actors. We call it the 3 pillars. Actually, the humanitarian pillar, the developmental pillar, and the peace pillar should have their comparative advantage. And these all 3 pillars should frame the achievement of collective outcome for all over multiple years. And then if we implement the Nexus approach in this way, the key gain is that the result we are going to gain from this implementation will be more than the individual gain we are going to gain by implementing in siloed approach. And now in Ethiopia, these are the current existing problem we have assessed while starting applying this Nexus approach in Ethiopia. And the problem currently existing in Ethiopia are recurrent. They are just protracted as well, and also they are complex in nature, varying from different sorts of crisis. And while these recurrent crises are occurring, the response being given to this crisis are very fragmented, especially in programming, and does not leading to the expected outcomes we expect and we anticipate. Again, there is no joint strategic planning between these actors, the humanitarian actors, the development actors, and the peer actors at high level and at operational level as well at the ground. More importantly, when looked at the current trend of the humanitarian response plan set at country level, the humanitarian need or the people targeted to be addressed by humanitarian need are increasing very largely, while the funding requirement to address these people in need is decreasing, especially in terms of proportion. If you see my graph at the right hand side, there are two graphs, and the number of targeted people shows this graph from 2013 to 2014. The people targeted were increased by tenfold, while the funding proportion required to fill these gaps decreased from 94% to 25%. So with this approach, in Ethiopia, there is a general understanding that we will not be able to meet this need if we continue implementing in siloed approach as used to be in the previous. And in terms of malnutrition, there is high level of malnutrition in Ethiopia, and this graph shows the current malnutrition status for under 5 children in Ethiopia. And starting from 2000 Gregorian calendar, especially where Ethiopia has managed to conduct Ethiopian demographic health survey the first time, a very comprehensive one, and this year, which means 2015, the stunting rate has been reduced to 14 from the initial 58%. There has been a reduction, dramatic reduction, especially before 453 years until 2016. But recently, after 2016, this shows a trend of increasing from 38% to 14%. So this shows that, again, we need to act in different ways by applying the Nexus approach in new way of working. The wasting status, underweighting status is also the same with high level of malnutrition in Ethiopia. With this understanding, yes, we know that this Nexus approach has received a global attention, especially on the ever large World Humanitarian Summit conducted in 2016. But there was no clear roadmap or framework which is endorsed to guide how each actor can translate the humanitarian development nexus approach into practice, especially at the ground level while responding to the need. But in Ethiopia, the Ethiopian Ministry of Health has conducted need assessments under the SUN Joint Annual Assessment into 2023 and identified Nexus approach as one of their key advocacy priority and partnered with Action Against Hunger, including the Disaster Risk Management Commission, and assigned ACF as a national technical lead to help and operationalize this Nexus approach into practice. Since then, Action Against Hunger has partnered with the existing stakeholder in Ethiopia, including different donors, international organizations, local organizations, as well as the key government line ministries at national as well as regional level, and worked on to design an implementation roadmap which will be effective until 2013, and also operational guide which will guide on the technical aspect of guiding how each actor will operationalize the Nexus approach in Ethiopia. And these two guidelines, the key framework, have just endorsed it in July 2024. And we have adopted the how triple framework in doing this. The key takeaway from this operational guideline is that Ethiopia has endorsed 7 key strategic objectives while doing this, which will help each actor just to apply. having the coordination and governance structure, having how to do the context assessment and need analysis, how to design scalable multi-sector, multi-year resilience programming, how multi-year and flexible financing can be designed, and having context-specific and harmonized M&D framework, and having localization agenda and local solution as a core component. And also the seventh point is having a conflict sensitivity approach in each of the programming in Ethiopia. These are the endorsed strategy objectives. And now, Action Against Hunger pursued these strategic objectives and designed a very comprehensive HDPN program, which is currently being implemented in Ethiopia for covering 5 regions. And it's a consortium having IRC, DRC, and 3 local partners as well. And this program is funded by SIDA through the Swedish Embassy in Ethiopia, and Norwegian Ministry of Foreign Affairs through Norway Embassy in Ethiopia. And this program has already started implementation in July 2024 and will be running through December 2027. And now this program has put expected outcomes around 5 key outcomes. The first one is enhancing food and nutrition security. The second will be having a gender sensitive and community-based DRM and natural resource management. And also the second outcome is increasing income and diversified livelihood for especially women and the youth. And the fourth one is actually covering a very important pillar, which is peace pillar, improved social cohesion through participatory peace building. And outcome 5 is just working around collaborative learning and coordinating among humanitarian development peace actors in Ethiopia. In doing this, programmatically, we have used a pooled funding approach rather than managing the funding in silos approach. We have applied a pooled funding and managed the program as one governance structure. We have also applied make a center of the program as localization agenda by provision of direct resource to local actors as well as capacity building. And also we have applied conflict sensitivity approach through conflict sensitive analysis while implementing this program. In terms of targeting, yes, this program has set a goal of improving food and nutrition security for the targeted households, and we have used malnutrition as an entry point, especially to target the geographic area in terms of prevalence, and also prioritized malnourished households, especially household having a malnourished child and mother, and consolidated the intervention package around these households. And in terms of the gender integration, yes, almost the program targets, out of the program target, around 52% is female, and especially outcome 2, 3, and 4 are mainly focusing on primarily on female-headed households. In terms of result we have gained through implementing this program so far, we were able to support more than 34,000 households through this period. The program is almost implemented for the last 2 years, almost nearly 2 years have through the program period, and we are flaring actually to make households having with improved food and nutrition security to enhance their community resilience capacity. In terms of specific achievements, we have helped households, almost nearly 14 households, to access and apply a climate smart agriculture technology and services. We have also helped households, almost 14,000 households, to have access and apply nutrition sensitive agriculture practices. We have supported nearly 2,700 households to apply community managed DRM and natural resource management. Again, we have supported nearly 2,000 people, especially women and the youths, to diversify their livelihood and increase their income. And in terms of the peace building pillar, we have almost supported around 500 to participate with peace building through enhanced social cohesion. In terms of advocacy, under this program, we have achieved two key gains actually. One is able to engage with donors and own the Nexus approach and revise their funding approach, and able to engage with SIDA and the Swedish Embassy in Addis Ababa, and also NORAD through Norway Embassy in Addis Ababa. And also we were able to manage and ensure government ownership in applying an access approach, especially in owning and implementing the operational guide and implementation roadmap, as well as this program as a whole in general. And nearly 5 ministries have engaged and owned this approach while implementing. These are the results in photos. These are female households accessing their climate smart technologies and also the nutrition sensitive agriculture technologies, and also females having formed the voluntary or village saving and loan association and having their income diversified and increased through this program period. This will be my last slide, talking about key learnings and the takeaways from the last 2 years. The one is, as I have already stated, we came across that the ownership by the government is very promising, and we are still working with the government to ensure that this is institutionalized through the Nexus coordination structure establishment, where all actors will be engaged and implement. And also, we saw again promising donors engagement. Again, there are a lot of works to be done at all levels to ensure that all donors revise their funding strategy, aligning with the Nexus financing approach. And again, we have found that localization is a foundational component of an Nexus approach as a ground, and increasing the funding proportion to local actors is very important, especially in terms of power influence capacity as well as decision-making capacity at all. And lastly, having a resource mobilization strategy, especially having a domestic financing strategy, is very important to leverage an external funding, especially in this scenario where international funding is being reduced as a country. And a very key important message for everyone interested to apply an access approach, need to realize that fundamental change, especially moving out of the comfort zone and the behavior, is very important for any organization when to apply an access approach. And also overcoming an institutional, structural, and political obstacle is also very important. And also supporting a contextualizing and confronting the one size fits all taboo is very important for all organizations wanting to apply an access approach as a general. Thank you very much. This is all what I have for you, and I will be coming back to address your question at last. Thank you very much.
Thank you, Hailu, and thank you, Dr. Adugna, too. Thank you to the whole SCF team for putting this together. Yes, we definitely cannot afford to continue doing business as usual. We must contextualize, we must coordinate, we must work with local national actors to do better as part of this Humanitarian Development Nexus. I can't agree more with you. You've clearly summarized in your last slide. I will quickly hand over to Nancy to share their experiences from Mali. Thank you. Nancy, you're still on mute.
Sorry, I am trying to pull up my presentation to share. So let's see, I think I'm ready. I'm going to turn it over to Hazara. Okay, Hazara, are you on?
Okay, thank you very much, Nancy. Good morning, good afternoon, everyone. I will give you a brief overview of the integrated nutrition programming delivered in northern Mali by Lutheran World Relief, which is a Corus international organization. And talking about briefly Corus is an ensemble of faith-based organization with a mission to urgently end poverty, suffering, and injustice in partnership with local actors, including community-based organizations, government regulators, and the private sector. The Corus brand was established after the merge in 2020 of long establishment in ENGO, Lutheran World Relief, and IMA World Health, and which now also includes CGR technology and our Grand Up investing arm. We work in the world's most fragile setting to support sustainable system, change needs to overcome the interconnected challenge of poverty, healthcare access, and climate change. And we lead natural and complex humanitarian responses with an aid toward building resilience. We do not aim to create parallel systems or recovery in our humanitarian response, but we work to strengthen the recovery of existing systems to help their communities withstand the current and future shocks. That was the basic for our emergency response to nutrition crisis in Mali in 23-24 that we implement with Gate Foundation support. So, as said, the context of this project was, if you see in the right, the map, we are working in the high-to-reach area, which are Tombouctou region and Gao region. And in partnership in mid-23, the region of Gao and Tombouctou were in emergency due to conflict-induced displacement of more than 330,000 people in northern and central Mali, contributed to a worsening food security crisis, and assigning Gao and Tombouctou respectively with IPC level 3, which is crisis, to level 4, which is emergency, and contributing to increase malnutrition across Mali, including 313,000 severe acute malnutrition cases, plus 1.1 million malnutrition MAM cases among children aged 6 to 59. In Gao region, SAM and MAM rates rose to 3.6% and 15.7% respectively, and health facilities facing therapeutic food stockout. As a result, acute emergency layered and chronic development needs, for example, I talk about stockout, underfunded health facilities, and community health programs. Slides. And the program intervention bring together two systems in one integrated response. First, LWR secured an emergency 12-month grant from the Gate Foundation to support addressing the crisis. Through this project, LWR procured locally sourced produced vitamin-enriched flour called Vitable, conduct food supply transportation, provide graduation food voucher to family of children, diagnosis with MAM and SAM without complications, provide agent kits to family, plus safe agent promotion, and support nutrition demonstration in communities. And in addition, LWR leverage the USAID Department of State supporting Momentum Integrated Health Resilience MHR ongoing project, which is a development platform to strengthen capacities of regional health services and health facilities to deliver and maintain a continuum of quality care. Here, I would like to highlight the fact that LWR and MHR have developed an incredible win-win partnership within the project. Because when we were informed about the stockouts at the health facilities in both regions, we reached out to the Gate Foundation and received positive response about funding. And then we come back to MHR, which immediately mobilized teams to support identifying the most at-risk health facilities and develop collaborative intervention to address the gap. MHR also ensured the overall operational coordination in the implementation process by facilitating access to 11 selected health facilities covered by MERL, mobilizing trained staff for us, facilitating access to the network of local food suppliers, mobilizing the existing community health worker network. The project benefits also from nutrition counseling provided by MHR program. And MHR also facilitates the use of government facility register for us. And as a result, an integrated emergency and development programming fill critical gap in the existing system rather than creating parallel systems. Slide. And in this program, what does the patient journey look like? It is a process of 4 steps, starting with community screening. Community health worker identifies mom's cases using MEAC, and then the child is referred to the facility of the 11 facility which are in our program for further assessment and enrollment by nutrition specialists. And in the step 3, the children receive the integrated treatment consisting of offering Vitable, which is an enriched flour, by weekly basis up to the recovery. And also they receive counseling, hygiene promotion, and also they receive hygiene kit to promote hygiene at the family household level. And also they are doing the follow-up visit. And the last step is the graduation step when families receive food vouchers composed of rice, millet, sugar, milk, oil, and beans. And at the end of the program, we are able to treat 2,862 children across the 11 health facilities and distribute 5,000 wash kits to families. And I will end it over to Nancy for the rest of the presentation. Thank you.
Oops. Thank you so much, Hazara. Can everyone hear me? I can't see my screen, so. Yes?
Yes, we can.
Great, wonderful. So we were hearing, anecdotal stories of pretty fast recovery times, high recovery rates based on this emergency response. And we wanted to dig deeper into that and get stronger evidence of the results that we were hearing about. So we designed a retrospective evaluation of the program. Many of you working in the Nexus or working in humanitarian programs probably know that you don't always get the opportunity to do an evaluation of the programming, but we were able to do so. And so we did a mixed method design, and we looked at records from all of the children treated as part of the emergency response at 9 of the 11 health facilities. And I say 9 because the records, unfortunately, were destroyed one from flooding and another just from wear and tear from two of the facilities. So we were not able to look at records from those facilities. So of the accessible records, we were able to analyze the data from 99% of those by trained data collectors. So these were doctors and other healthcare providers that were very familiar with nutrition data and with facility registers at the facility. And they spent no fewer than 2 days per facility going through patient registers, entering the data digitally, and then we did the analysis. We looked at sort of traditional outcomes for treatment of MAM, including recovery and cure rates, mortality rates, dropout rates, and non-response rates, all versus SPEAR standards. And we also looked at mean treatment duration. As I mentioned, we were able to include all accessible records of children 6 to 59 months who were treated for MAM, or in a few cases, SAM without complications as part of the emergency response nutrition program. We also wanted to dig deeper into caregiver experience with the program. We did 36 key informant interviews with caregivers of treated children. Purposive sampling, we had pairs of trained interviewers. They transcribed the interviews in French and then translated to English. We looked at the quantitative outcomes that we were seeing in relation with the qualitative themes in what is called a concurrent mixed methods design. Before we did the evaluation, we did get ethics approval from the Mali National Ethics Committee, who ended up being really great sort of technical advisors throughout and participated in our sort of project and data validation meeting as well as next steps meeting. So they ended up being not just reviewers, but kind of key technical advisors throughout, which was great. We, of course, got informed consent for all participants for the key informant interviews. There was no personal identification data collected from the retrospective record review. It was all like the aggregate, kind of data that we ended up looking at from facilities. We did cross-check all exit classifications. So when a patient was considered cured or dropped out or non-responsive, we checked that against all the criteria in the Mali National Guidelines, and fewer than 1% required corrections. So we were working with high quality data other than the destroyed records, of course. Limitations to this design: there's no control group, it's not an RCT, it's retrospective, and then for the key informant interviews, it was a 2-month recall period. So we interviewed caregivers in some cases after they had, exited the program for a couple months. We saw extraordinary outcomes. The emergency nutrition response program had a recovery rate of over 97%, which is well above the SPEAR standard and well above averages from previous studies in the region. Very low dropout rate at 1%, 0 mortality rate, and the median recovery time was 28 days. So the anecdotal evidence that we were getting from our staff in the field was confirmed by the results of our evaluation. Again, I had mentioned the high data quality, and I think we were able to show that, the integrated approach of this emergency response through sort of established health facility relationships that the Momentum Integrated Health Resilience Project had built achieve both emergency speed results and development quality outcomes. So these are some of the results from the key informant interviews with the caregivers. 80% reported positive influence on future healthcare use. 97% had appointment, so reported, not missing appointments even without any incentives provided. I should note that the graduation food kits were given at the end upon successful treatment, and they were not told ahead of time that they would be getting those. 100% of caregivers continued seeking care post-program at the health facility, and there were 0 negative comments about healthcare staff. So when we interviewed, these were open-ended questions. We did not say, did you have any negative experiences with healthcare staff? So we were obviously very pleased with kind of the feedback that we were getting from caregivers about their experience with the programming. And one of the what we could consider spillover effects was that the intervention strengthened ongoing development relationships and trust in the healthcare system, which is so key, especially in conflict settings. These are just some of the quotes from caregivers, kind of following those themes of, they were really visibly seeing dramatic results in their children, and it was increasing their trust in the system. And so they were feeling more empowered and more trusting to go to the facility for other reasons besides just the nutrition treatment. And also, of course, a big factor was that week in and week out, they were receiving the Vitable packets from the facility with no stockouts. So as you all probably know, working in this sector, stockouts are one of the main reasons that people lose trust in the system and stop going to facilities. Some of the other success factors, that it was culturally appropriate, easy to prepare therapeutic food, which was the Vitable fortified flour, which is locally produced in Mali. As I mentioned, they were having visible results among their children, and it motivated caregiver engagement, and then positive provider relationships, and then the integration that we did with trusted existed facilities. There were, of course, some barriers. Wasn't all perfect. The caregivers mentioned some husband resistance to women taking their children to facilities. Just time conflicts with domestic responsibilities, competing with clinic visits, and transportation costs. And one thing I did want to highlight is that we are continuing some of this program through Momentum Integrated Health Resilience Project. And we're also partnering with LWR. And one of the things that we're providing is caregiver meals to caregivers of children that are in the inpatient treatment program. So that will directly address some of the barriers with competing domestic responsibilities. System level challenges, I don't think these are new to most folks here. We did experience, I think, a couple of minor stockouts, but they were able to quickly be addressed. As I mentioned, the hard copy registers were destroyed for 2 facilities. So that's not just nutrition data, that's patient data that was lost for, 3 months. And then there's tensions with doing things quickly, with doing things, as part of the system and including all the key stakeholders. Short put inputs versus long-term supply ownership is still something that needs to be addressed. And humanitarian staffing versus government capacity. But I think, what we learned through caregiver interviews, through working together in these partnerships, and through talking with staff in the data validation workshop is that these are solvable, and they're not major barriers that should sort of preclude doing an intentional design between emergency response and development work. So as I mentioned, I know I don't have a lot of time, but we did have a dissemination workshop for the results of the evaluation, and it included 20 participants from pretty diverse key stakeholder groups. And some of the outcomes of that workshop were an endorsed integrated model. So they really wanted to scale this model up of, therapeutic treatment, hygiene promotion, nutrition counseling, community health worker, in addressing supply chain issues. And then prioritize government-led facility record digitization. So we all recognize that the destruction of the facility records is a big problem. And I don't think it's unique to Mali, but that is something that the government was very much committed to, working with donors and implementing partners to get facility registers digitized. And They also emphasize Vitable as a sustainable alternative during stockouts of other RUTF and recommended a second phase of this project with a geographic expansion and then a more rigorous evaluation of the model. So something prospective. So these are 6 possible actions for replication of this model and for addressing barriers. They're pretty self-explanatory, but scale the integrated service delivery model, digitize facility records, leverage the healthcare trust to expand to other services. So nutrition could very much be an entry point for families accessing other services like immunization, maternal health, and child health. Investing in male engagement strategies, particularly in contexts like Mali, where the husbands do still very much have a say in women and child healthcare seeking. Strengthening community health worker accessibility. One thing that caregivers mentioned was that it would be good to have the contact information readily available for the CHWs in their health facility catchment area, and then a more formalized peer referral network. They also, this came out of the validation meeting with government and implementing partner stakeholders, and they recommended having high-performing facilities share practices with facilities that were having more challenges, which I think is a great idea. Basically, the common thread throughout all of this is build government and local capacity. Don't bypass it, even during emergency and humanitarian responses. So these are some questions that we've had, after the evaluation, after the implementation of the project, and some potential next steps. Basically, do these results that we see in an emergency nutrition response last, and at what cost? One thing that we didn't do, because it was not a mandate and it is, it wasn't an emergency situation, was any type of cost effectiveness study. And so we all feel like that is an important next step when we're talking about scaling. And then, of course, looking at 6-month post-graduation to see if the results that we saw, the really outstanding results that we saw, held, and looking at relapse, and then also the graduation food kits, did they provide kind of the lift needed to continue the gains that we saw? How big is the health system spillover? So we did mention through the caregiver interviews that it was sort of an entry point to seek additional services. So looking a bit deeper at, do these integrated nutrition programs facilitate more health service use? And you could look at that through, other data that's routinely collected. Does the model hold beyond the sites? So of course, kind of expanding and really testing a little more rigorously to see and establishing some very clear scalability criteria. And then, just for more context, in Mali especially, the government endorsed the Vitable and recommended a second phase. Mali's National Malnutrition Protocol was developed in 2017. It is due for a revision. So a phase 2 of this project is very much timely, and the evidence would arrive right at the right time with the government's work. So we're hoping to, as I mentioned, we are expanding through MIHR some of this model, but still hoping to do a more rigorous evaluation. Have to acknowledge everybody that was involved. It was fast and furious project, but it went extremely well, and we could not have done it without Adugna, who is now with the MIHR project in Mali. He was our country evaluation lead. Amadou is my colleague at Corus, who helped out in the field doing data collection. And then Aminata is our chief of party with MIHR Mali. And Gianu, who I'm not sure is on, helped us with some of the data analysis. And then, of course, the Malian caregivers who generously gave us their time to talk about their experience with the program, and Gates for funding, and then our partnerships with the local partner in MIHR. So that is it.
Thank you, Nancy. Thank you so much for that very interesting evaluation that was carried out. We have very limited time, but I think I see two questions. I think you probably answered one in a way, which was looking at the number of children that you reached versus the 1.1 million moderately vulnerable children, and how you see this as being scaled up across the country. And I know you've talked about being scaled. You've talked about phase 2. Is phase 2 going to be scaling up to geographically, or is it scaling up in terms of numbers, but in the same geographical space? And just in 1 minute, you can answer that question, but probably also respond to, if you think, you and Hazara can respond, if you think there's any plans for domestically sustainable financing or domestic financing in general.
Great questions. I cannot probably speak to the domestic financing as much as and I will also defer to Hazara a bit for the scaling. We have expanded our geographic regions as part of MIHR. So I do want to be clear that the Gates funding was to fill a very sort of immediate need of the therapeutic food stockouts in these facilities. So it was intended to be in the 11 facilities that MERL supports, and that's where the program targeted. So, those are that with the amount of funding that was received, that was the number of children that we could serve. But I will say that because the treatment rates were, we were seeing cure rates so quickly, we were actually able to provide the treatment, the food, the Vitable to more children than we had originally envisioned. But we are expanding to additional geographic regions within MIHR, and this integrated pieces of the integrated project are being continued as part of that. I'm going to defer to Hazara. So Hazara, anything else on that? And then, of course, the domestic financing for this programming issue.
In a minute, Hazara. Thank you.
Sorry.
Yeah, about the domestic financing of the program, as Nancy said, we conducted a workshop to share the result of the program, and it is a way for us to show the government, to advocate, and to see how the government can take over this program to scale up this program. But the advocacy is still continuing with them. Thank you.
Okay, thank you. There's quite a lot of interest. Someone is asking about the composition of the Vitable flour, and is it a product that can be replicable in other settings and as an alternative to RUTF or even RUSF?
So this is the key question. So we can get the exact composition. We'll have to send that out later, but I did want to highlight that the Vitable was used for MAM and not SAM with complications. We did have some children that ultimately, once they came into the facility and were assessed, did fall on that border of SAM, and we saw the same positive outcomes with them that we saw with the MAM children, but we did not use Vitable for SAM with complications or inpatient treatment. So I think that's a key distinction. And I should also say that it has not been evaluated in any sort of comparative effectiveness trials with standard art like Plumpy Nut. So I do want to make those caveats, but we saw very high levels of cure rates with the Vitable with MAM children.
Great. I do hope we'll have some 1 or 2 questions coming in for the Ethiopia team. But in the meantime, we still have some 4 minutes. We have Mike, who has worked in Mali before, and I think is currently the nutrition advisor with JPEGO, is asking about the capacity to reproduce Vitable in large quantities, given that there are challenges in getting sufficient amounts of misola and other fortified blended foods. Or misola, another type of fortified blended food. So I think it's a question around challenges to do with getting the required ingredients in large quantities?
I am going to defer to Hazara on that because I do not know the
Yeah,
production
I
situation.
think I met the Vitable unit a month ago, and they have the capacity to produce at large scale, and it just depends on the needs, because we need to, if we wanted the production, we should maybe express the need and they will produce. But for now, they are producing for Mali, and Vitable is available everywhere at the field level, at the community level. It is available everywhere in Mali. Yeah.
Thank you. And I see someone, I think Adama has posted what it is, which is really wheat, soybean, oil, and sugar. Okay, thank you. I'm not seeing any other questions in the chat. We do still have a couple of minutes. Hill says that the price point for this product is high for many mothers. If you have to, now move it to the resilient part where again, we're talking about the humanitarian development peace nexus. People resilient means they now probably start having to find these products and utilize them on their own. And Hill Holy says it's quite high for these mothers. So maybe I'd add on and ask, are there strategies of how that can be looked at in terms of reducing the price point for the mothers in the longer term? In just 30 seconds, then we'll be wrapping up. Thank you. You're on mute.
Yeah, I was actually going to see if Adama and then our chief of party, Aminata or Hazara, had any quick thoughts about that. I think we've discussed the price point a little bit. It is high, but not any more so than regular foodstuffs that families would be purchasing. It is flour. So we've had a little bit of internal debate about this, but yeah, just wondering if we have any thoughts from our Mali colleagues.
Yeah,
well, we do have 1 minute.
Yeah, I want to add also that the Vitable unit, they are now trying to produce the small quantity of Vitable so that it can be available for even the most vulnerable mom can, buy it for children. Yeah, they are working on that.
Thank you very much. We'll come to the end. Thank you everyone for having joined us. We'll be sharing the presentations and the available articles with you, and hopefully we can continue these discussions and engagements with the speakers that we've had today that will also be sharing their contacts at some point. Thank you everyone. Enjoy the rest of your day or your evening, and see you and hopefully to engage with you some other time to
And
come.
thank you, Core Group, so much for hosting this. It was great. And we enjoyed meeting our AACF colleagues. And
thank you.
Take care, everyone.
Thank you very much, Martha, and all as well.
Thank you.
See you.
Bye.